Innovations worth spreading. Revolutionizing clinical thinking and practice with 10 innovative frameworks and ideas. Clinical medicine is more than just remembering facts. It's about thinking fast, thinking clearly, and acting for impact. The future of perfect clinical decision-making lies in using cognitive schemes, frameworks that guide fast, analytic thinking while keeping care patient-centered. First, the HP scheme, H for hypothesis-driven history and physical, and P for patient-centered history-taking to answer two questions. The first, what is the matter with the patient? Conduct hypothesis-driven history-taking and focused examination. Prioritize the most probable and the not-to-miss diagnoses, using clinical prediction rules like the Wells score for pulmonary embolism, and applying likelihood ratios to symptoms and signs. The second, what matters to the patient? Identify the physical, the psychosocial, and the personal values shaping every decision. Second, a true diagnosis is more than naming a disease. With the DIP scheme, the tri-label diagnosis, your diagnostic label is complete. Disease, identify the biomedical cause. Illness, understand the psychosocial impact. Preferences, respect patient and family choices. Avoid preference misdiagnosis, where our plan fits the disease but not the person. Third, every disease diagnostic label should be complete to mirror the guidelines recommendations. The BES scheme. B, bedside clinical diagnosis. E, etiological cause. S, severity score or grade, to decide on the site of care and appropriate immediate interventions. The fourth, don't stop at one differential. Add a second step. Consider both phenotype, based on the first differential diagnosis step, and endotype, based on the second differential diagnosis step. That's how we make precision medicine real, not just theoretical. Fifth, when treating, remember the 5S scheme: site of care, symptomatic treatment, supportive care, specific treatment, specialty or senior referral. Sixth, safe discharge needs the ACT scheme: assess response to treatment, determine your criteria for discharge, smartly plan the timing of follow-up. Seventh, medical education in evidence-based medicine must shift from abstract appraisal skills to knowledge translation as a core competency. That means staff are competent in running evidence-based ward rounds, journal clubs, M&M meetings, patient-centered decision-making, discharge planning, and quality improvement initiatives through knowledge translation tools, etc. Eighth, in postgraduate training, case presentations should mirror the core competencies expected of trainees. For example, the CanMeds competencies. Clinical actions must reflect all the competencies for a hands-on competency training and a holistic care package. Medical expertise, communication, advocacy, collaboration, leadership, professionalism, etc. Ninth, to transform care, use the 7 E's for patient and staff engagement. Envision, embrace, empower, enlighten, emphasize, energize, evaluate. Whether it's patients or staff, engagement changes everything. 10, for system improvement and transformational outcomes, follow the care blueprint for redesigning your service. You are aiming for 4 strategic achievements. Number 1, clinical excellence. Number 2, academic innovation. Number 3, return on investment, the financial return, and number 4, experiential outcomes, happy patients and staff. Leadership support, standardization, competency training, and monitoring make it a reality. This is the future of clinical medicine. 10 novel frameworks. 1. Gather information HP scheme, H&P, history and physical, hypothesis, driven and patient-centered. 2. Comprehensive diagnostic labeling, DIP scheme, disease, illness, preferences for comprehensive patient-centered diagnostic labeling. 3. Disease diagnostic labeling that is guideline-friendly, the BES scheme, bedside diagnosis, etiology, severity. 4. The second differential diagnosis step, endotype as well as phenotype. 5. Therapeutic interventions, the 5S scheme: site of care, symptomatic, supportive, specific, and specialty or senior input. 6. Discharge Planning Act scheme, assess response to treatment, criteria for discharge and timing of follow-up. 7. Undergraduate medical education, the KT competency, not just EBM teaching. 8. Postgraduate medical training, the competency structured case presentation or discussion. 9. Patient and staff engagement, the 7 E's: competency, envision, embrace, empower, enlighten, emphasize, energize, evaluate. 10. Quality improvement, the 4 elements of the care blueprint: clinical excellence, academic innovation, return on investment, and experiential patients and staff outcomes. Structured thinking, patient focus, precision action. Because when we align the science with the human story, we don't just treat disease, we transform lives.